Hi, my name is Javed Syed. I'm a vitreoretinal surgeon. Here I am presenting a case of a patient with TB chorioretinitis. Although I've given you the diagnosis, I'm going to walk you through how this patient presented, what our imaging and testing looked like, what our differential diagnosis was, our workup, and our plan of care. And I'll also show you or tell you how the patient responded to treatment. The patient was a 55-year-old female who was sent for optic disc edema and cystoid macular edema in the left eye only. She had reported a 1-week history of floaters and blurred vision in the left eye. She denied any associated pain, and she denied any issues in the right eye. She did not have any fevers, chills, cough, shortness of breath, joint pain, or rash, not currently on any systemic medications, and she denied a history or denied any current systemic diseases. She had immigrated from Africa several years ago, notably, and had had the BCG vaccine in the distant past. The vision uncorrected in the right eye at the time was 20/40, and the left eye was 20 hand motions. Her exam was significant for a mild AC reaction in both eyes, the left eye more than the right. It was also significant for anterior vitreous cell, again, left eye worse than the right. On dilated fundus exam, it was noted the patient had a few chorioretinal spots, as well as an inferior localized serous detachment in the right eye. The left eye exam was more dramatic, with diffuse chorioretinal spots, multifocal serous detachments, and 4+ disc edema. This is a picture of the right eye. You can note the multiple chorioretinal spots, as well as the localized area of inferior serous detachment. The left eye exam is more dramatic here again, with multiple intraretinal hemorrhages, chorioretinal spots, multifocal serous detachments. An autofluorescence shows hyperautofluorescence around the chorioretinal spots, as well as delineates the area of serous detachment. In the left eye, much the same, there's areas of hyperautofluorescence that both show the chorioretinal spots and the areas of serous detachment. An angiogram of the right eye. Here is an earlier frame. You can see some blockage by the chorioretinal lesions. This later leaks and pools in the area of serous detachment. The nerve is also hyperfluorescent, denoting inflammation. Same in the left eye. In a later frame, we can see some vascular leakage, denoting some level of concurrent vasculitis. An ICG of the right eye shows blockage from the chorioretinal spots, much the same in the left eye. An OCT through the lesions show disruption of the outer retina in the right eye. In the left eye, there's serous fluid, disruption of the outer retina, as well as changes or irregularity in the RPE. The differential for multifocal chorioretinitis is broad. We think of inflammatory and infiltrative causes such as VKH, posterior scleritis, sarcoid, and neoplastic causes. We include sympathetic ophthalmia here in the differential just to make people think, but this patient did not have a history of intraocular surgery or a history of penetrating intraocular trauma, and therefore sympathetic ophthalmia was not really in the differential in this particular case. We also think about infectious causes such as Bartonella, tuberculosis, toxoplasmosis, Lyme, syphilis, endogenous endophthalmitis lower on the differential, but we keep it in the differential regardless. Our workup is as follows. In conjunction with the patient's PCP, we drew a CBC, an ESR, a CRP, an ANA, an RPR, an FTA antibody, ACE, lysozyme, Bartonella titers, Lyme testing, toxoplasmosis titers, HIV, and a chest x-ray. Topical steroids were initiated. The plan was to plan for intraocular or oral steroids if the infectious labs came back negative. The labs and chest x-ray testing were all negative except for a positive quantiferon gold. And this is indicative of active TB, even in the setting of a prior history of a BCG vaccine. The patient was therefore sent to infectious disease for RIPE therapy. And after discussion with infectious disease, adjunctive oral steroids for inflammation were started after a few days. With steroids and antibiotics, the subretinal fluid resolved, and the granuloma slowly resolved. In the right eye, the results were quite good, with an intact outer retina centrally. In the left eye, unfortunately, the degree of scarring left the outer retina as well as the optic nerve damaged. As the steroids were tapered and the antibiotics continued, it was noted that the subretinal fluid started to recur in both of her eyes. The steroids were therefore restarted at a slower and tapered much more slowly. As the steroids finally came off, the SRF, or subretinal fluid, remained resolved. The final visual acuity off of antibiotics and off of steroids in the right eye was 20/30, and in the left eye was 20 hand motions. Things to take away from this, although rare in the US, TB should be included in the differential for chorioretinitis. The BCG vaccine does not exclude the possibility of active TB, and steroids initiated after antibiotics may be useful in some cases to control the inflammatory response, but should never be used alone. Again, this is Javed Sayed presenting a case of a patient with TB chorioretinitis. Thanks so much for watching.